Hi everyone, welcome back to Medsurvival Mnemonics. Today we will be tackling acute heart failure exacerbation treatment with an easy to remember mnemonic, LASIX, LASIX. So first of all, we need to know what LASIX stands for. L stands for loop diuretics, especially the IV loop diuretics. A stands for arterio and venodilators. S stands for sodium and water restriction. I is for intensive monitoring, and X for oxygen. So we'll study one by one. So as far as loop diuretics are concerned, there are three loop diuretics that we can use in patients with acute heart failure exacerbation. The most common is furosemide, also known as Lasix. The second is torsemide, and the third is bumetanide, also known as Bumex. The chart for the equivalent doses of these three diuretics is shown. As you can see, the 40 milligrams of oral furosemide is equal to 20 milligram of IV furosemide and is equal to 20 milligram of torsemide, either oral or IV, and 1 milligram of oral or IV Bumex. So first of all, we need to know what should be the dosage of loop diuretic that we need to start in patients. There can be two kinds of patients. First, the patients, they are already on diuretics at home, and the other ones are diuretics naive. If the patient is already on diuretics at home, we need to increase the dose by 2 to 3 times, or roughly 2.5 times. We need to convert the dosages as per the table that I have shown earlier. And if the patient is diuretic naive, means never used any diuretics, then we need to start with the Lasix, 20 to 40 milligrams IV in a day, or torsemide, 10 to 20 milligrams, or Bumex, 1 milligram. So if there is inadequate response to these diuretics, then we can double the dose. The response to diuretics can be assessed with the urine output. The next thing that we are going to discuss is arterio and venodilators' role in acute heart failure patients. The most common arteriodilator that we know is IV nitroprusside, and we know that arteriodilators decrease after load. So they're very effective in patients who have heart failure along with severe hypertension or mitral regurg or aortic regurg, as all of these situations need a decrease in afterload. The venodilators are more often used in heart failure exacerbation. The most common venodilator that we know is IV nitroglycerin. So how does the venodilator act? They decrease the preload. So it's the same mechanism. That's how the diuretics act. So when do we need the venodilator? When the patient is resistant to diuretics. So despite maximal dose of diuretics, patient has suboptimal response. So another important thing in heart failure patient is sodium and water restriction, and believe it, the sodium restriction is way more important. The total amount of sodium that can be allowed to a heart failure patient is 2 grams in 24 hours. The mnemonic for monitoring is HEART, HEART. So H is for hypotension, as patient is on diuretics, it needs to be monitored for low blood pressure. E for electrolyte abnormalities, especially potassium and magnesium. The level of potassium should be more than 4 and magnesium should be more than 2. They should be monitored either daily or twice daily. A is for alkalosis. It's another metabolic alkalosis is another side effect of loop diuretics. If patient has severe metabolic alkalosis, then we can use one-time dose of acetazolamide, 500 milligrams or 250 milligrams can also be used. R is for renal insufficiency. One thing to remember is that whenever we start diuretics in a patient, mild degree of renal insufficiency is expected and actually shows effectiveness of diuretics because the diuretics decrease the volume, decrease the preload to the kidneys, and can lead to mild degree of renal insufficiency. However, when the renal insufficiency continues, it is a red flag. T is for telemetry. As patients with heart failure are increased risk for arrhythmias, that's why we need to monitor these patients on telemetry. The last but not the least is oxygen therapy. We need to know what patients don't need oxygen. If the patient oxygen saturation is more than 90%, we should not use oxygen. Why? Because oxygen can lead to pulmonary vasoconstriction. And when there is a pulmonary vasoconstriction, it decreases the preload and cardiac output. But when we use oxygen, what should be our target? Oxygen saturation. Generally speaking, it should be between 90 to 95%. However, if the patient is a COPDer, so this patient has COPD, now has acute heart failure, we shouldn't go that high. So it should be on the upper end of 88 to 92%. And that's the Lasix mnemonic to simplify acute heart failure treatment. If you found this helpful, don't forget to like, subscribe, and share this video.